We've got a number of different perspectives, folks that if you know them, it is to respect them. They're really smart, thoughtful, authentic, courageous leaders in healthcare and health policy. And so we're really honored to have them with us here today. I want to welcome them to the stage. First is President and CEO of Blue Shield Care First Health Plan of California. That's Buchert, Dr. Greg Buchert. Margaret Tatar, the Managing Principal of HMA, and the Acting Director of Los Angeles County Department of Health Services is Christina Ghaly. Why don't you come on up to the stage, all three of you. Let's give them a round of applause. And we'll have, at some point, we'll have microphones running around with Margie and Rita here, and after you're done eating salad and chicken and fish and all that good stuff, you can ask questions as well. Christina, let me start with you. Let me just give you this sort of softball, open-ended one. You can take it where you want, which is, what are the sort of issues and topics and data points that you're spending your mental energy tracking in healthcare today?
Sure, thank you, and good afternoon, everybody. It's great to be here. There's a lot of things going on, as we all know. I think the things that occupy my time and my mental energy are a few. One, on the federal stage, obviously this CMS administration has taken some postures that are challenging for us here in California and here in LA County at the Department of Health Services in particular. We're closely watching for the executive order on public charge. We're closely watching CMS's administration and their recent guidance on Medicaid waivers. The 1115 waiver is absolutely essential for us at the Department of Health Services. And based on the most recent guidance that's been handed down from CMS, Department of Health Services stands to lose upwards of about $300 million a year starting in 2020 if there's not, or 2021 if there's not change in that guidance from CMS. We're watching the DISH delays and whether or not the DISH cut delays would continue to happen or whether they would go into effect in 1920. On the state level, I think there's also a lot going on. Certainly we'll have to watch at the governor's level what the posture of the new administration is, how they manage the issue of universal coverage, and then how the transition with health homes and whole person care goes. And then certainly for us here more locally in LA County, we just have a lot of continued work to do to continue to improve the health system for the lives that we take care of. We take very seriously our responsibility as the safety net for LA County. We have, upwards of 400,000 lives impaneled to us within the Department of Health Services, a mixture of Medicaid managed care, IHSS, and uninsured. And we really want to take good care of that population and have still a lot of work to do in terms of improving access and quality and efficiency of care to be able to do that really with a high degree of stewardship and faithfulness to our mission. And with that, the challenges of trying to take care of the whole person, and I mean kind of whole person with lowercase. How do you take care of their behavioral health needs? How do you take care of their substance use needs in the light of the carve-outs and the separation and the financing flows and the siloed funding streams? How do you try to work within that very complicated system so that from the patient standpoint, it's seamless and we can be an end-to-end provider for them? It takes a lot of work and a lot of effort, and still there's much to do on our part.
Awesome. 400,000 people impaneled. Quantitatively, continue, if you would, sketch out your department. How many hospitals, and give us the numbers of everything that you do. The $400,000 impaneled patients is a big number. You got other big numbers too. Why don't you share some of those?
Sure. So the Department of Health Services operates 4 acute care hospitals in LA County. You probably know many of them: Harbor UCLA Medical Center in Torrance, LACUSC Medical Center in Boyle Heights, Rancho Los Amigos National Rehabilitation Center in Downey, which is also med-surg and acute rehab, and then all of you UCLA Medical Center in Sylmar. We also operate about 25 standalone clinics across the county broadly. We serve about 500,000 patients a year. About 95%, our patient mix is 94%, 93, 94% uninsured and Medi-Cal. We have about 3% Medicare and a very small smattering of commercial insurance, mainly that comes in through trauma, the ER, burn services. But by far the vast majority of who we serve are Medicaid, fee-for-service and Medi-Cal managed care, and the uninsured, and we're proud to do it. We also operate the EMS agency agency which helps to work on the overall emergency medical services system across the county. And so in doing so, we do work with a number of different private hospitals across the county. And then we're also proud to host the My Health LA program, which is a program that helps provide some funding for primary care services within the Community Partner Network. And I see some community partners out there in the audience, so great to have you here as well.
Great. Margaret, let me ask that second question of you first, which is, tell us about HMA, your scope, the work you're doing in California, but also just the work you're doing nationwide. HMA has gotten big over the years, and people may not all know the story.
Thank you. Thanks for having me here today. Good to see everybody in the audience. I'm with Health Management Associates. We are a health policy firm. We have locations now in about 27 states. So we work all over the country. Our focus is the publicly financed space. Traditionally, at the beginning of our organization, back in 1985, we were considered to be really a true policy shop. We were the place where lots of former Medicaid directors who, when they retired, decided that they weren't ready to retire, so they came to HMA. And having moved from that origin, the sort of policy space, we now have a lot of clinical leaders. We have a lot of physicians, psychiatrists, psychologists, nurses, all kinds of practitioners, as well as folks who are more focused on operations and the delivery system operations, as well, of course, as the underpinnings, who we have always been, which is a policy shop whose heart really is in the Medicaid space. I'm the managing principal in Sacramento, and I also manage the San Francisco office. Those two offices really focus on a few specific things: managed care delivery system issues. We have a lot of work in whole person care and health home programs. We do a lot of work in the plan space and provider space. And then our San Francisco office has a fair amount of public health and exchange professionals, as well as folks who work in the correctional health space, which of course is growing in complexity and frankly need. So thank you.
So Margaret, working in Sacramento and Northern California and in your prior role at DHCS, and you have been able to watch this Medi-Cal waiver from a number of different perspectives, pre, post, et cetera. Christina mentioned losing $300 million as a consequence of not getting the waiver re-upped in 2020 for 2021. Give us your prognostication and your sense of the waiver development. What does that post-2020 world look like? Meaning, when this waiver ends, should we expect greatness out of the next waiver? Will there be another waiver? What are your thoughts on that conversation?
Well, one always assumes greatness will follow, but it's really hard to think about the gap in terms of what California can reasonably expect to realize. And it's a very reasonable expectation. Those who have known me a long time know that I'm never one to be overly optimistic when it comes to anything related to financing and where we are when Medicaid gets under attack. I'm always looking for icebergs, and certainly we know what lies ahead. It's not invisible to us. So I think that with that in mind, certainly one thing that has been a theme of the sessions you've been to today, a theme that Christina alluded to, is this imperative really for us to do a better job of integrating care. An imperative for us to avail ourselves of the current programs in the current waiver, including the PRIME program, the whole person care program, the health home program. That's not a waiver program per se, but it'll be launched in counties starting in 2018. And then the good work that, the systems like Christina's system and the payers do in order to really promote And it's not easy. It's easy to talk about it, but it's actually very challenging to effectively accomplish it. But to really promote the kinds of contractual relationships that are necessary to knit together a system. So, I mean, when we talk about a delivery system, it's not as though there's this sort of standalone system with, you know, a tidy package that we can all avail ourselves of. It's a system that's knit together through payer contracted networks, provider fulfillment of commitments to those payer arrangements, and all of the ways that we knit together specific initiatives, whether they be waiver funded, funded by other plates or funding sources, and really work in the community to knit together that which isn't really a standalone system per se. I think that's going to become critical. It's been a goal of ours for years. Those of us who have worked in this space for a long time, we've talked about the imperative for integrated delivery systems and integrated care. Now it strikes me as an imperative.
Greg, I want to first give you 20 seconds to tell us about Care First, because I want to get right into the follow-up question. But I want to make sure you could give us the same answer that your two previous speakers addressed, which is, you know, give us the scope of Care First, number of lives, geographic activity, et cetera, et cetera.
So Care First has been operating the Medicaid space for over 2 decades, one of the original participants in Medicaid managed care. And it's now, having been acquired by Blue Shield in 2015, is able to leverage the resources of that nonprofit organization, has actually converted to a nonprofit organization. And we serve about 500,000 members in California. We have, the bulk of our members are Medi-Cal members. We happen to have about 400,000 members in LA County itself, but we serve members in about 435,000 Medi-Cal members, about 70,000 Medicare members, and we have about 5,500 dual eligible members that we serve through the CalMedi Connect program. And then there's that combination of ones where we see some with Medi-Cal, some with Medicare, and there's got about 70,000 of them.
Yeah.
And I'd be remiss if I don't point out that on January 1st, 2019, we will be changing our name from Care First to the Blue Shield of California Promise Health Plan.
And October 1, you're essentially fully integrated into Blue Shield, correct?
That's correct.
Yeah, so for internal reasons. So let me ask you this question in follow-up to Margaret and Christina, which is, as a plan CEO, but as one who's been at, you know, Care First now, prior you were CEO of California Health and Wellness, you were the CMO at HealthNet, you're a physician by training. You've been able to wear a lot of different hats for a lot of different years on Medi-Cal. What gives you hope about this 2019 reprocurement? And what continues to really sort of grind at you that we haven't yet figured out how to solve heading into this 2019 reprocurement?
What gives me hope about the reprocurement is it's an opportunity for hopefully an upgrade and improvement in services that we're offering. Now, this is a once-in-a-generation activity because the state really has not reprocured contracts for many, many years. It gives an opportunity to take a fresh look at how we're doing our business, how all health plans are doing their business. And just to put in perspective, there's about 16 contracts across the state that'll affect several million members. And so hopefully the members will benefit from either improvements in existing plans or with the new plans that come in. I think what's challenging with the reprocurement is that it's a change of health plans or potentially continuation of the same. But there are some of the things that Christina pointed out that just structurally aren't changing with the Medi-Cal program. And like Christina, I share her passion about the disdain for carve-outs, and I'll give an example of a complex child in the Medi-Cal program. As a health plan, I've got responsibility for his or her needs, but the child has a chronic illness, there's another funding stream for CCS. If they've got behavioral health issues, there might be county-based behavioral health services. There's the DentalCal program, there's the school-based LEA program, there's DentaCal, and there's still some fee-for-service activities. What that means is that there might be multiple case managers, there might be a lot of confusion, and you can drill it down to just the day-to-day activities of, as a physician, I could write a prescription for 3 different medications for a complex child, and one's billed to the health plan, one's billed to CCS, and one's billed to the state fee-for-service program. And so I think the structural components of Medi-Cal still need some tweaking.
Yeah. So Margaret, what are your any insights on this question of why have policymakers both in the legislature and at the various agencies not been able to sort of conquer this carve-out challenge? In other words, if I start with the premise that if you unify the dollars, rather, it's very difficult to unify and integrate the care if you don't unify and integrate the dollars. And that one might argue that carve-outs are sometimes driven by politics, maybe different than on-the-ground care delivery. Why have we not seen a trend to end carve-outs more broadly, drive integration more directly, and instead we seem to have kind of backslid away from a unified care financing model to a broader range of carve-outs? What are your observations there as a Sacramento kind of insider and somebody who's watched this very closely?
Well, I think certainly, Greg and Christina articulate what those of us who have been doing this a long time and everybody realizes to be true, that carve-outs or silos that make optimal coordination of care for the person, not the funding source, that is challenging. It's unambiguously a challenging element of the program, the Medicaid program. But carve-outs, I think it's important to do 2 things. One, take the long view. So remember, and again, those of us who have been doing this a really long time, we know that the whole idea of moving populations into managed care and moving fragile populations into managed care that has not been time immemorial. Managed care historically in California, really was for the TANF population. Now, the county organized health system models, we had all of the populations mandatorily enrolled, and the COEs, of which Greg and I worked together in one, we had all of the populations mandatorily enrolled and therefore had very specific experience with all of the populations, and we had more of the benefits enrolled for years ahead of all the other plans, like the long-term care benefit, right? Now, having said that, managed care became more universally accepted really only in the last 8 to 10 years, for purposes of the more fragile population. If you look chronologically, again, the state of California moved seniors and persons with disabilities into managed care for all the plans only in 2010 and 11. So again, and that took some doing with the advocates. So that's only 7 years ago. I can tell you when we were when I was in the administration and we did a few other initiatives, we moved the rural counties into managed care. We still faced a lot of questions about the value of managed care. When we did the coordinated care initiative, which integrated Medicare and Medicaid for duals in 7 counties, again, and that was only 4.5 years ago, we faced some questions about the value of managed care. When, again, we all know that breaking down silos and mitigating the adverse impacts of carve-outs makes good sense. So now having come to this point, 2018, looking to 2020, On a certain level, the good news, I think, we can all agree, is that the premise that there is a very valuable role for managed care to play and for the payers to play in terms of driving integrated care through their payment policies and delivery system contracting, the premise that that's a positive thing is really asked and answered. DJ's question really presupposes at its core that the managed delivery system makes sense, because now we're not talking about if we have a managed care system, but rather how much is the managed care system going to be asked to do. So I think that's one theme that's worth sort of positing in our minds. Medicaid by its nature doesn't change overnight. It is incremental. It is a program that moves incrementally. It moves by legislative changes at the federal and state level. It moves through the 5-year cycles of 1115s. And in California, you see one county Medicaid system with one kind of Medi-Cal managed care delivery system. You see one, right? Second thing then, if you assume the proposition that the managed delivery system is tested now, is in place, and you have the partnerships to which Christina alluded with the payers in LA County, which is altogether positive in terms of plan-payer relationships, then it becomes a question of what more will we ask the plans to do? Will we carve in more benefits? Will the plans be ready to assume responsibility for those benefits? Greg alluded to CCS. CCS is being carved in some counties. We're waiting to see how that goes. Will we see a carve-in of dental in more counties? In some counties, that wasn't a good thing 5 years ago, but maybe we'll see dental carved in. If we see more carved into the plans and expectations that the plans do more of what we've all heard about today in terms of health home, whole person care, integrating the social needs of very vulnerable populations, addressing the social determinants in a much more meaningful way than we have. How will the plans do that? How long will it take? How will we ensure that the plans are ready for that? How will we ensure that staff, the people who do work, we've all talked about community health workers and the way that they knit together systems and knit together needs. How will we modify planned case management programs? How will providers and hospital systems modify their case management programs so that the knitting occurs? Because without really being concrete about the people who will do the work, we can't assume it'll magically happen. Does that make sense?
It does. There's a lot there. That's good. Christina, I'm wondering if the question I'm going to ask, I'm not going to ask it this way, but is sort of like a prioritization from your view of some of what you just heard Margaret speak to. So I'll ask that this way, which is, you're a physician by training, you run a provider shop now, it's a big shop. You're on the board of LA Care, so you've got a governance perspective at a plan. But with your provider hat on, what would you really like MCOs, health plans, to be advocating for in this procurement so that you could be better served by your MCO partners? What would you like to get from MCOs to take care of your population better that they should be, advocating for in Sacramento, putting in their proposal and figuring out a way to collaborate with you on moving forward?
So I'll answer that. I do want to build off of some thoughts that Margaret made just on the carve-out. I think in any discussion about the carve-outs and what their future is, it would be remiss to not point out, as I think Margaret did, there's an important reason why they're there. The history of managed care in California and the United States is not perfect, and in part, some of these carve-outs or all of them came into being because there's various complex or vulnerable populations that either weren't being well served or there was fear would not be well served within a shift which was happening fairly rapidly toward managed care. And so I don't think that any discussion of the carve-outs now and what their future should be should ignore the importance of that part of their past. And I think the important thing moving forward is, as Margaret said, there's a natural evolution of Medicaid, and what worked 10 years ago or 20 years ago maybe isn't needed or isn't needed in the same structure or way today, and that's important to take into account. But there are real concerns and fears and anxieties, and those are based on real facts in terms of how patients have experienced care and what their own personal life experience has been with the healthcare system. I think with that context, as we look forward to the procurement, as we look forward to our relationship ongoing with, in LA, the two-plan model, to start with, I think the two-plan model is absolutely critical, and we are firm supporters of it and would like to see it be maintained. It's essential for helping to maintain the safety net in LA County. In terms of the procurement, I think that there's a lot of ways in which the plans have been good partners to us and could continue to be good partners, whatever is the outcome of that procurement. And much of it, I think, DJ, really is where you've said in terms of really trying to advocate for a different way. We have invested a great deal into housing within LA County Department of Health Services. We invest tens of millions of dollars every year into recuperative care, interim housing, stabilization housing, and permanent supportive housing for patients who are served by the Department of Health Services. We were able to do that financially because of the finances at the beginning of the ACA with high rates, a high FMAP, and high enrollment. Those things change. The FMAP moves down, the PMPM has moved down. There's not a sustainable funding stream for being able to continue to provide really what are critical services for patients in terms of stabilizing their health and their lives. We know the plans are supportive of that in theory, but we need to make sure that there's a stable revenue stream to be able to fund it. And it's not just housing. The same could be said for multiple areas of social determinants of health. We need to make sure that there's the funding streams through the federal government as well as the state government to be able to support those critical services for our patients. And I think the health plans can be good partners. I think the danger for all of us is we do a good thing and it's the right thing to do, so we will keep doing it to the extent at all possible. And then all that happens is the actuaries look at the utilization and the rates are cut. And then you're back to square one. And that's not a situation that is good for any of us to be in, and it's certainly not good for the plans as well. So I think there's a lot of advocacy and really trying to think about what's the future of gain sharing arrangements, what's the future of risk sharing arrangements, how can you do shared savings, how can you structure different funding pools on the federal level through social services, or at the state level, so that we can try to actually weave together something into a program that really can, in a sustainable manner, meet the needs of patients in ways that they need to be met. I am an internist by training. I see patients every week, and I see it still in my clinical practice at LACUSC and at all of you. You're not going to stabilize the heart failure. You're not going to stabilize the diabetes. You're not going to be able to heal the wound that keeps, reopening up if they're living on the streets, if they can't get access to stable food sources, and ultimately if they don't have a hope of, educational or vocational training, of opportunities to connect with community resources or something that gives their life a broader structure and meaning and purpose. And we want to be a part of that solution. I do believe that the plans want to help be a part of the solution, but we have a lot of work to do with our federal and state partners to try within the broader context to make that happen. And I know there's interest in the state as well. There's wonderfully mission-driven, committed people at the state, and they're up against some constraints on their own on the federal level. But I think working together, hopefully we can try to find a way to make this be a sustainable program for our patients.
I want to be open to your questions here in a second, so I'll ask Greg a question, but then I'll look to you for you all to raise your hand, and we'll get you a mic. Greg, if it's just you and me over a beer and no one else is in the room, we might say that, there's a lot of talk around behavioral health integration, has been for the last number of years, and integration of all sorts, ending carve-outs of all sorts. And where the rubber has met the road amongst some health plans, not named Care First, there has been more talk than action, more marketing than success. In other words, collectively, we're still not standouts on this integration front, and there are a lot of reasons why that's the case. But do you think that there's reason for people to be maybe cynical of ending carve-outs because health plans are, generally speaking, good at managing dollars, but maybe not always very good at managing care?
Well, since we're in that bar, cheers.
Yeah. This is my third. I'm going to have to knock it off here in a second.
Yeah. You know, historically and currently, there really is so frequently this divorce between the head and the body. And we don't treat behavioral health issues the same way we treat cardiac issues, GI issues, respiratory issues, and there's a lot of aura of difference with behavioral health issues, whether it be mental illness, substance use, or others. And I think some of it is structural, the fact that there are sometimes different funding streams. In the health plans, it's only been a couple of years ago that the plans assumed responsibility for treatment of mild to moderate conditions, and the county maintains responsibility for inpatient services and severe mental illness. One of the challenges that's been set up with that is the fact that what is that break point? And having worked previously with a plan that served 19 counties, there were 19 different break points between moderate severely ill and severely ill. And so I think there's a lot of structural things that get in the way. And I think that there's one of the things as providers, putting my provider hat on, is often a lack of familiarity or lack of comfort with behavioral health issues, but yet at the same time there's a recognition that behavioral health issues impact compliance. And so I think the physician and other provider recognition of the need to acknowledge behavioral health issues. I think the communication in the community, among providers, among health plans, among the health department, and education of how to access those services is getting better and better as we communicate at the higher levels more effectively, all with an eye to how do we take care of patients better and better.
Good. Let me, like I said, look to you, and if you want to raise your hands, we'll get you a microphone here. Right here, Margie in the middle. And sir, identify yourself and your name and your organization, rank, et cetera, et cetera.
Rank, serial number. I'm Michael Monaski. I'm a writer. I live in Sacramento. Managed care, carve-outs, silos. Are these euphemisms for austerity cuts for medical services for real people? That's kind of the question. And then just a couple comments. The PPACA forced Congress to buy its own health insurance, just like any other government employee, but then never mind the fact that most members of Congress are at least millionaires, folks who can afford health care at full cost and can actually utilize the medical deduction. So again, managed care, carve-out, silos, are these just euphemisms for neoliberal austerity cuts for medical services to real people?
Who wants to take that one?
I'll start. I think Christina put out a good point. Is actually, I think the carve-outs are somewhat vestiges of protections for people who had real needs. If you go way back, there was the CCS program when kids didn't have health care for their chronic conditions. You had a number of things, and so they were put in incrementally to fund care where care wasn't universally available. I think as you've seen the evolution of managed care and a willingness to take on more and more responsibility for a whole person, it's a transition from expensive silos, and I think that by combining them and eliminating the silos, you actually do become more cost effective and have better coordinated care, as long as there is accountability to make sure that the needs of the patients are met. That something is not lost in that transition or consolidation. So I actually think it's the silos are more costly than less costly?
I would add that I think your question reflects a critical issue, which is the promise of managed care. So California policymakers and a lot of policymakers who moved populations into managed care, and certainly some of the efforts that California undertook recently, had to do with the premise that in a complicated county or system or area, when a beneficiary is expected to be his or her own sort of navigator and figure out his or her own transitions of care from a very expensive and long-term inpatient stay or arranging care amongst the silos that exist in a fee-for-service system, the promise of managed care has been that the managed care plan and the case managers and all of the additional benefits and protections that the states require of managed care, that they don't require a fee-for-service, inure to the benefit of the beneficiary. So for example, managed care plans are held to quality standards that don't exist in fee-for-service. So beneficiaries now in California can avail themselves of a dashboard, or their caregivers or advocates can, and they can see exactly how the managed care plans perform from a quality perspective. The managed care plans are funded for health education. They receive funding for all kinds of case management benefits that are, to which they are entitled through the plans, that you simply don't have access to in a pure fee-for-service arrangement where you are accessing your fee-for-service doc, you're making all of your arrangements yourself. So your question's a great one. It goes to the core value and the promise of managed care, and I think what we're talking about today as we look to the future is, will that promise of managed care really help us to bridge this period of time from 15 through 20 into the next period of time? And will the plans continue to be able to really avail themselves of the data that they have to really know their beneficiaries, really know and use the data that they have in order to develop those care plans, work more collaboratively with their communities, and make sure that not only do they demonstrate quality on a publicly available dashboard, but can they demonstrate better outcomes? And I think we can all expect the state's going to use its purchasing power in the procurement for just that proposition. Thank you.
Other questions from you all? How about way up? Do you want to take a shot at that, Christina? Okay.
Is this on? I'm happy to answer. I think the devil's in the details. I think you could do it in a way where either way, you could keep the carve-outs and do worse care, you could keep the carve-outs and do better care, you could end the carve-outs or some combination and do better or worse. It's absolutely in the implementation and in the intent of the implementation. I will say that as what I've seen from my perspective as a provider, personally and across the organization, it's challenging to navigate, and it's challenging to navigate for patients, and there's inefficiencies. On the plan side, there's administrative redundancy with all of the back office infrastructure that's needed to run all these carve-outs. On the care manager side, it's redundant. I've met patients who have 5, 6, 7 care managers. Some of that's our fault. They've got a specialty care manager, a primary care manager, their inpatient care manager. That's a problem we need to fix. But then they've got a care manager, case manager at the plan. They've got one on the mental health plan. They may have one in the, organized delivery system under drug Medi-Cal. They're all over. And then all you do is end up trying to manage the care managers. That's not a good outcome for patients. But I think your question is the right one to ask. But I think it depends on what you decide you want to be doing. What are the values and principles that you want to uphold and what you're trying to achieve, and then the devil's, as always, in the details of how you implement.
Let's get a microphone up here, Rita or Margie. Thank you. Why don't you stand up and just again introduce yourself, ma'am?
So I'm Stephanie Booth. I'm at the bottom of the totem pole as a pediatrician. And I've been dealing with this for quite a while now.
You have to hold
But
your
I'm
microphone a little
wondering-
closer. There you go.
Okay. I'm wondering is it possible? I'm always interested in patients being accountable for some of their own care. Is it possible to make the system simple enough so that would happen, so that they could, I mean, I just remember my mom trying to deal with some of this stuff, and she is one sharp lady, and she'd have papers. It took 10 minutes to figure out who to call.
Yeah.
And then it's really difficult to navigate, and I think for the best care possible, either the patient or whoever the patient's advocate is needs to be able to do some of that.
Yeah, good question. Who wants to take this about how do we sort of both simplify the system, but also try to empower the patient or the patient's advocate to do more of the work of care management?
I'll start. I think it's a great question, and I like the somewhat reframe that you put on it, DJ, about empowering the patient. And I agree. I think patients should have some responsibility for their care and should take that responsibility. I don't think we make it easy for them. I know historically within the Department of Health Services, still within the Department of Health Services in LA, we don't make it easy. You know, you call this number, they refer you over there, they don't answer the phone, or they tell you the wrong info, and then you've got this form and that form. We're still trying to correct a lot of that and fix that. And then again, you layer on the multiple plans and other delivery systems, and it's complicated. It's complicated, especially for people who don't, like us, live and breathe healthcare all day, every day. But I think that the twist that we have to put on it is both correcting our own systems and then really trying to empower the patients and help them to want to own their care, help them to want to help be managers of the care that they receive and take on a more vocal voice and helping to be a leader in what they receive.
There's some glimmers of hope out there. So a couple of glimmers of hope that I think, started in very specific programs. So many of you may not know about PACE. PACE is called the Program for All-Inclusive Care for the Elderly. Fantastic program, started in 1971, a boutique program for duals. The cornerstone of PACE, it's a bricks and mortar affair, you go into a PACE center, but the cornerstone of PACE is that the way that the interdisciplinary care team works for the member, for the patient, and the fact that the interdisciplinary care team and the member work on a plan. There is a plan to which the patient, member, enrollee agrees, works collaboratively on that plan, and I think it's one of the hallmarks of PACE's success with a very highly vulnerable population. You have to be nursing home eligible in order to get into a PACE program. We've borrowed that. So we borrow that, you see that in MA and dual eligible special needs plans. We borrowed it when we did the CCI program in California, integrating Medicaid and Medicare. We're doing health home program now. You're seeing this development of a care plan in the emerging health home programs. You see the development of a patient involvement, of a member involvement in whole person care. People are agreeing to a care plan. And it doesn't sound revolutionary, but I think it's an incremental step to get to empowerment. Because the idea that we engage with a member sufficiently so that we plan their care together is comparatively novel in the Medi-Cal managed care space. But I think it's a cause for hope.
You know what's interesting? At Blue Shield, our vision is to create a healthcare system worthy of family and friends and sustainably affordable. And as a healthcare executive, as a physician, and perhaps most importantly, as a father of a son with significant disabilities, and having us on the other side of the exam table, having had to interface with social services, Department of Rehab, Department of Education, go on and on and on. I'm one person, and I approach it every day to say, how do I take care of individuals? And I think that you're hearing more and more about that whole person care, and that increasingly, I think we see that we need to focus. We talk about population health, but increasingly you see that we're looking at people or individuals who live in families, who live in communities. And so the fact that we're even talking about things like social determinants of health helps also recognize the fact that it's not just that doctor visit, that hospital visit, whatever it may be, but it's what do we do with communities? And so I think that's part of an important aspect of what we do and need to do more and more of, is look at the individual in the community.
So we're getting out of time here. I want to sort of ask each of you for just kind of some closing thoughts and frame the question this way. First with you, Greg. I always like this one because it gives us a window into how you think about the future, about your thoughts on leadership, and in some ways a sense of your value judgments and statements. And the question is this: what counsel or advice would you give to this room of folks as they try to lead their healthcare organizations? What should they keep their eyes on? What should they stay oriented towards in terms of a direction or a vision? What advice do you give them?
I'm not going to stray too far from my last answer. It's really easy to get caught up in politics, finance, administration, and a lot of hullabaloo that's often distracting. But keep your focus on the individuals that you're serving day in and day out. No matter what type of organization you're working in, you're still taking care of individuals one by one.
Margaret, same question.
It's hard to follow Greg's sage advice, and so I won't ditto, but I do ditto that. I think it's important to focus on, for all of you, and certainly I think all of us have done that. We have lived this. I think it's important to really focus on the fact that when we undertake new programs, when we undertake anything new, whether it's health home programs, whether it's the development of new initiatives to more appropriately empower members, if it's the development of a care plan or new case management programs, new ways to make the system work better, I would just urge everybody to ponder two things. Number one, when we articulate that new thing, make sure in your organizations that everybody understands it. And that means really trusting your leadership and their directors and their leaders to make sure that this new vision, whatever it is, gets appropriately woven into the fabric of your organization. It doesn't just magically happen, that good idea and sound operational implementation thereof. That takes a very significant investment of your time, your organization's resources, to make sure that if you hire community health workers to do all these fabulous things that we're talking about in terms of knitting together the system, they need to be trained. They need to understand how your organization works and where they fit in. And then secondly, while that is going on and while you do it every year and you make it part of who you are, you evolve your organization along with your expectations, your cultural leadership and the leadership with which you imbue your direct reports is critical, because you have to remind everybody that this is the new normal. And that's how I think you move the dial to something that's going to be more member-centric. Thank you.
Christina, your counsel for this audience?
I mean, absolutely, the focus has to be on the patients. That's why, hopefully, we all do what we do. I think, though, in keeping the focus on the patients, I know I have to struggle, and I've seen this in my team, and I've seen this, I think, everywhere. It's the struggle to resist against defending the status quo. if you want change, it's by definition disruptive. Someone's going to lose, someone's going to win, someone has to do something differently. Maybe some organization doesn't have the same value proposition that they used to have, or maybe they don't need to exist. I think about that for public hospitals. I do believe that public hospitals are needed in California. Not every state has public hospitals. Is there a future in which public hospitals are not needed in California? I don't know, but I think my responsibility to the patient has to be open to that. I don't think that's where we are today. I think for a variety of reasons, they're absolutely essential as a safety net given some of the trends and demographics in California. But I think we have to be willing to question and resist that tendency to say, well, the change has to be out there, but not with what I do. And I think the only way that we're ever going to achieve the kind of transformation and disruption in the healthcare system is if we all, including me, are willing to say, okay, what actually has to be different about what I do?
Dr. Christina Ghaly, Acting Director of the Los Angeles County Department of Health Services, Margaret Tatar, Managing Principal at HMA up in Sacramento, Northern California, and President and CEO of Blue Shield Care First, Dr. Buchert. Let's give them a round of applause.